Dr. Sandra Springer is an infectious disease specialist and an expert in substance use disorders who's joining us from Yale this morning. And she's very well experienced in both HIV care and also integrating substance use disorder treatment and to some extent research is also another main focus of hers around the intersection between substance use and HIV and its complications. She is going to be talking to us today about managing substance use disorders. So Dr. Springer, welcome. Thank you, everybody.
Thank you very much. It's really awesome to be here. And I got to go to Sandy Springs last night, so that was really cool. And I thought, and I also we didn't plan this, but Mike Sag and I are dressed similarly, so I also think that's so 30 minutes to talk about managing substance use disorders, really tough, but it is something that I'm passionate about. These are my disclosures. These are the learning objectives. I won't go into it, but one thing that was just mentioned, that is the focus of my work, is integrating substance use and HIV prevention and treatment for those who are the most vulnerable, and really hoping that you come away with not only potentially how you would identify somebody with a substance use disorder and potentially consider treatment, but why the integration is so absolutely critical, and also other things we need to think about for our population who use substances. So this is the outline, and I'm going to just briefly go through this, the epidemiology, then screening measures you can use, and treatment, and leave you with some of our recommendations. So, because I can't go into all this, it was actually feedback from this one in the New York City meeting that we had last year about putting together a website or a series of talks that were about addressing all the substance use disorders. So thank you to the IAS-USA organization. Ellen Eaton from UAB and myself helped put this together. And there's lots of talks, including how to do contingency management for stimulant use disorder, alcohol use disorder, tobacco use disorder, and of course, opioid use disorder. How many here are aware of the MATE Act? Okay, so the DEA removed, you no longer have to get an X waiver, but for all of you who have controlled substance license, you have to complete one time an 8-hour series of trainings to be compliant. So just FYI, if you didn't know that, you need to do that. This whole series, it's free on the IAS-USA website. You can go do it all in one fell swoop or take your time, and it's free, like I said. And you would fulfill your requirement. So the problem, in a nutshell, we have a significant number of individuals who have reported use of substances. This is obviously an underestimate. This is from National survey drug that was predominantly for individuals who are housed. So we have to remember individuals who are unhoused or those who are involved in our justice system are not included in this and have a significantly higher proportion who use substances. And then when we get into those who actually have DSM-5, substance use disorders, you can see the numbers there. And I'll specifically be focusing the most of my talk on opioid use disorder, but again, this is an underestimate. And then, as you know, overdoses, deaths from overdose have been continuing to rise. So even in individuals who do not have a substance use disorder, so we have here, you can see the waves of that I'm sure you're very familiar with. But starting with the early prescription opioid epidemic, then quickly turning to black tar heroin from Mexico, then and then we started to see the big increase in synthetic opioids, mainly fentanyl. But I just wanted to remind everybody it's not just the opioids, it's also stimulants and combined stimulants in our fourth wave here that are contributing to a significant amount of deaths in our country. And I'm sorry to say there is not a decrease right now that is looking at all in any of our states. So the other problem is, and I don't have time to go into all of this, but other areas that I work on, and I'm sure you do too, is that we are seeing these increase in rise in substance use also associated with significant increases in other infectious diseases, so bacterial, fungal, serious infections. We're seeing it in our hospitals, right? Endocarditis, other infections, as well as acute hepatitis C, and then, of course, HIV. And this is nowhere meant to be a conclusive overview of all of our HIV epidemics that have happened since the early opioid epidemic in Scott County, Indiana in 2015 that was directly related to prescription opioid oxymorphone. But since that time, in Medicaid and non-Medicaid expansion states, significant outbreaks of HIV in individuals who use drugs, not just injected drugs, in states where, like Massachusetts, just north of me, wonderful healthcare system, but really we saw an outbreak that occurred there in a couple of towns, Lawrence and Lowell, where a significant association with those who are unhoused, and the mayor had put a moratorium on syringe services and methadone programs, but since that time we've seen a decrease in other areas of the country. And this is just a summary slide, just to remind everybody that substance use, drugs, and alcohol increases the risk of potentially acquiring HIV through not only condomless sexual intercourse, maybe disinhibited in that aspect, or exchanging sex for drugs, other issues like that, but also sharing injection drug use equipment. But even in those who have HIV, substance use, ongoing substance use, can interfere with the HIV care cascade, make it difficult to adhere to antiretroviral therapy, obviously then unable to maybe maintain viral suppression, and then from a public health standpoint, if one partakes in high-risk behaviors, there's an increased risk of transmitting HIV. So when we think about this, and this is really always what I've wanted to do, is you can't just treat one in isolation, and this is what I do, and there's many who are calling for this, is that it's our job to ask individuals if they use substances in a non-punitive way, and if so, do they have a substance use disorder that requires treatment? So that requires screening, diagnosing, providing the medications or other behavioral services, and not just starting, but ensuring that we can help people retain and care. So the identification, so from NIDA colleagues, Nora Volkow and others, this is just a nice paper to remind everyone that measurement-based care, so what if you have a diagnosis, it should lead to immediate treatment, which includes opioid use disorder. So if you identify somebody in the hospital, in your clinical care, wherever it is, harm reduction program, really think about that we could actually provide a treatment, and I will go through this, that's life-saving, and also will help individuals, if they do have HIV, stay in care and maintain viral load suppression. So just a reminder, for those of you who are not aware of all the Diagnostic Statistical Manual, 5th edition, which is the Bible of diagnosing, as you know, all psychiatric conditions, including substance use disorders, I just put it up here. And just to remember that it's no longer abuse or dependence, it's substance use disorder. And these are the 11 criteria to meet a substance use disorder. All you need are 2 symptoms to have a substance use disorder. You don't need to meet the former criteria of withdrawal, dependence. And importantly, moderate to severe, so 4 or more symptoms for moderate, severe, 6 or more symptoms, is the reason why I highlighted that. So if you have opioid use disorder, our current medications are FDA approved for moderate to severe. Now, not everybody knows all those symptoms, so it's really important for us to be able to screen. These are just some of the screeners. There's many more, but the one I highlighted is the NIDA Assist. It's free, and there are skip outs. You can put it in your electronic health record system, and then you can identify each type of substance use. So the quick way to do this is just one quick question, which is the NIDA question. In the past year, how many days have you used the following prescription drugs for non-medical reasons or illegal drugs? If they answer just one of those, you would then move to the NIDA Assist, perhaps, and then move forward in identifying the particular substance use disorder. We have also developed a couple of tools that actually diagnose, it's not just screen, diagnose opioid use disorder. And importantly, we validated these for individuals who are not clinicians. So for me, it could be a navigator, patient navigator, community health worker, research assistant, somebody who can do this and in less than 5 minutes gives you a moderate to severe diagnosis of opioid use disorder with the intent that you can offer treatment. And I don't get anything for it, just letting you know. So these are the treatments. So how many of you prescribe buprenorphine for treatment for opioid use disorder? Great. How many of you use naltrexone or extended release naltrexone? Methadone, as you know, we cannot offer in our clinical settings unless you're in a licensed opioid treatment program yet, although there's movement, hopefully, to move that forward to primary care. But the methadone just is showing you the differences in action. So all 3 forms of treatment, just to summarize, reduce opioid craving and reduce use, and have been shown to reduce overdose deaths. There's just enormous amount of data, but there are differences in their action. So methadone is a full opioid, mu sits on the opioid receptor, and the idea is that you'd reduce use, reduce craving for other opioids, and reduce, obviously, the harms from that. Buprenorphine, partial mu opioid agonist, but also partial antagonist, has a fixed dose in in multiple forms now. Sublingual doses, tablets, sublingual tablets, as well as films. There was an implant that we had for 6 months, probufene, not currently available. And we have now two injectable forms of buprenorphine that are monthly. I'll go through those. And then we have the opposite, which is extended release naltrexone, a full mu opioid antagonist, so full blocker, think long-acting naloxone. I didn't say oral naltrexone because oral naltrexone is not effective in treating opioid use disorder, but extended release once monthly injection is. And then I just identified the 2 that you could provide in your primary care or HIV care setting are buprenorphine and extended release naltrexone. All 3 reduce risk behaviors, so sharing injection drug use, as well as there's some data for sexual risk, and I will show you some data about also improving viral suppression. So this is just a summary slide of what I just said. The key things also to remember that for addiction or substance use disorders, it's not just abstinence that we're trying to get to, although opioid abstinence is nice because it decreases the risk of death, because any use right now, and it's all fentanyl, is a high risk of death, but also can help improve access to your normal life, getting a job, reacquainting with family members, et cetera, so it's important. But buprenorphine and methadone can treat opioid withdrawal and pain. They're opioid agonists, and extended release naltrexone can't do that. So this is just a summary slide I put together about thinking about who you might want to use this with. And again, I put an extended release naltrexone because it's an opioid antagonist, it's a blocker. You couldn't use this in a withdrawal situation, right? You're just going to make it worse. And also, it's not appropriate for somebody in acute pain needs. And from a clinical standpoint, it's really difficult to initiate. I have protocols in the community to start extended release naltrexone, but it's really hard for a lot of people because you have to be abstinent from opioids for about a period of 5 to 7 days, and that in itself is difficult to do. But in the hospital, other settings, one could do that. Buprenorphine and methadone here, both safe in pain conditions and other things. Oh, it's not working. The clicker's not working. I'll try this clicker. Nope. Oh, there, thank you. Oh, I missed a slide. Oh, I guess it's not there. So, well, anyways, so one of the problems, though, unfortunately, with all 3 forms of treatment, and the slide's not here, is unfortunately we have poor retention on treatment. All the clinical trials, as well as clinical care, very few people retain on treatment. And we have to think about, is it because it's difficult for them, or is it difficult for us to keep people on treatment, and how to overcome that? So long-acting forms of treatment, as I mentioned previously, are options, including long-acting forms of buprenorphine that are easier to initiate than extended-release naltrexone. And both of these forms, I currently have 3 clinical trials using Sublocade, and those who are in the hospital, those who are in prison and jail, and those who are veterans. And there's really no concern about safety issues, et cetera. But this is just showing you some of the differences in how one might administer them. And if you want to ask me about it, I don't have time to go into it. Happy to talk about it after this. So briefly, when we think about starting buprenorphine, this is a summary slide, and it's in your syllabus. But the way I break it down are individuals who are currently in withdrawal. They're in withdrawal, as I'll show you. Those you easily start buprenorphine. It's a no-brainer, and it's one of the best things ever. If you've ever treated somebody who's in withdrawal, it's the best thing to see when your patient goes from agonizing clinical symptoms to feeling relief. The individuals who are reporting use of opioids who are not in withdrawal, those individuals are a little bit more difficult in terms of how to start, but I'll show you. One could start even when they haven't gone through withdrawal and continue their opioids. They're continuing to use with the intent that they will eventually stop while you ramp up the buprenorphine. That's a well-known now appropriate approach. And then the others are that you might wait till they get into withdrawal, which is the way we used to do it, which can be very difficult. And then the other population are those that aren't currently using but are more at risk for relapse, especially those coming out of a confined setting like prison and jail, where the #1 cause of death of all individuals, regardless of how long you've been incarcerated, is overdose from substances. That's a population we really need to be getting people on treatment. That one you have to go lower and slower, and the same would be maybe at a long, prolonged hospital stay. So this is the clinical opioid withdrawal scale. You're probably familiar with it in the hospital, but it's really nice, and you can determine the stage of withdrawal, and in the red box tells you the level of symptoms. That's an easy thing to do, and you can help monitor that because you want to see the withdrawal symptoms decrease as you start treatment, and of course not increase through precipitated. This is just also for you to look through about the 3 different strategies of traditional buprenorphine initiation, overlap when they're continuing to use, and in both a 6 to 7 day or a 3-day rapid protocol. And you can just see on the bottom in the red box are the concerns for precipitated withdrawal would be in the first one and lower in the other 2, and then this shows you. So and I also gave you the reference so you could read that. The key, and this comes to the question that I had in your syllabus, or the pre-assessment questions, are really we shouldn't be delaying treatment of opioid use disorder. You can safely initiate it in the hospital setting. You can safely initiate it in the community setting. And that's the key. If you're going to screen and diagnose, you have to be able to offer something to them, whether it's not you, having somebody who has expertise that they can rapidly get to. And then, start the treatment. You can do all the other things, hepatitis C, B, STI treatment or assessments. And you don't need liver function tests and EKGs and really in-depth assessments. It's really safe to initiate. And then the other part, which I'm going to comment on, think about the other needs that we really have to help individuals overcome other issues that might interfere with their ability to retain on treatment. This is just a brief slide to show you the data about how these treatments can improve likelihood of maintaining or achieving viral suppression if they do live with HIV. Early studies I did a long time ago with colleagues at Yale, but first this was a study that we did right after buprenorphine became FDA approved for non-licensed OTP programs to administer. And so this was great. We could offer treatment for the first time with buprenorphine for people as they were coming out of prison and jail who are living with HIV. And the goal was to see not their opioid treatment or response, but really could we help maintain viral suppression? And we did. Then later did the quintessential double-blind placebo-controlled trial of the first injectable form of treatment for opioid use disorder, which was extended-release naltrexone in the same population, with the primary outcome looking at viral suppression, and of course, providing treatment prior to release and continuing it helped individuals with HIV maintain viral suppression. And no increased adverse events. They all had high degrees, 60% had hepatitis C, ongoing use, so you don't need, and we published on that, you don't need to stop treatment and assess LFTs. For alcohol use disorders, as we know, it's a very prevalent, and it's much more prevalent in our population who has HIV, and also increased toxicity. For alcohol use disorder, there's also, as I'm sure you're familiar with, very easy screening, free assessments. But the NIAAA's question, which can prompt you to then further assess alcohol use disorder, is, do you sometimes drink beer, wine, or other alcohol beverages? And how many times in the past year have you had 5 for men or 4 or more drinks in one day? If they answer that yes to that, that's supposed to prompt you to do another assessment. So the audit C is a very easy one, 3 items, and you can see in the yellow, it'll give you a score with the concern of an alcohol use disorder. Other considerations, number 1, considering medication treatment, which I'm going to go through. And again, with this one, there's a lot of data supporting that abstinence may not be the goal, especially for alcohol use. It could be low-risk drinking, so what does that mean? You have to have a conversation with your patient about that. And then, of course, the other big one is before you offer treatment, you want to know if they've had a serious alcohol withdrawal experience, including delirium or withdrawal seizures. That's a population stop that needs to be admitted to detox prior to telling them to stop drinking, because they're at high risk of developing serious withdrawal symptoms. And then there's also many forms of behavioral treatment, as well as 12-step programs that can be very helpful for individuals. So these are the 4 FDA-approved medications for alcohol use disorders, and in the red box, the 2 most effective in terms of clinical trials are the naltrexone formulations, oral and extended release, and then there's also acamprosate and disulfiram, which are less effective, but maybe for some patients might be ones that you consider. Disulfiram, you have to be careful, as you know, with the increased toxicity if somebody continues to drink, including VFib. This is just another study just to identify that issue that I talked to you about, that if we integrate treatment for alcohol use disorder and with antiretroviral therapy for individuals living with HIV, that you can also do the same thing as the studies I showed you for opioid. You can improve their likelihood of maintaining or achieving viral suppression. So this was, again, one of those double-blind placebo-controlled trials showing you that, hey, if you start treatment prior, in this case, again, individuals who are being released from prison and jail, you could not only reduce their alcohol use, but also help improve the likelihood of maintaining viral suppression. And again, no increased toxicity. Stimulant use disorders, okay. So this is our toughest one, right? So cocaine use disorder and amphetamine-type stimulant use disorder is how they're described in the DSM-5. For me, it's cocaine. For you guys in Atlanta, other areas, it's mainly methamphetamine. And it's really, really hard to treat. But just to caveat, even somebody who has opioid use disorder, when they're in treatment with buprenorphine and others, they're doing a good job, right? They're coming back free for treatment. The big problem is the ongoing stimulant use, and we shouldn't be removing people from treatment for opioid use disorder because of ongoing stimulant use, but we should be offering them other assistance. This is just a diagnostic tool that was also created to do rapid diagnosis for stimulant use disorder, moderate to severe, validated for non-clinicians. It takes less than 3 minutes and you get a diagnosis. So just putting that up there. But you can also use a NIDA assist and other DAST. Sadly, with stimulant use disorder, we don't yet have FDA-approved effective medications to offer like we do with opioid use disorder. That being said, there are treatments that we could consider for some populations to help. The best form of treatment for stimulant use disorder is a behavioral form of treatment, which is contingency management. How many know about contingency management? So it's an incentivized-based, well-studied method that actually reduces stimulant use. But the key is you have to offer it and how you offer it. And there's a wonderful lecture on that series that I told you on IAS-USA website for the substance use disorder given by Stephen Shoptaw at UCLA that really goes through the evidence and how to do that, and I highly recommend that you look at that. There's a wonderful reference now that was put out by ASAM, American Society of Addiction Medicine, and AAAP, this American Association for Addiction Psychiatrists, that's for the first time ever really goes through management of stimulant use disorder, and it is highly easy to read. And I don't have time to go into it, but I had put 2 slides together of the medications for both cocaine use disorder and stimulant use disorder, and the efficacy and some side effects that one might consider them. And so I highly encourage you to look at that. This is a slide. I took this in DC when I was there a couple months ago, the harm reduction vending machine. So just to remember that not only, it doesn't matter what substance they use, but we should be offering harm reduction tools to everyone, importantly naloxone. And also thinking about significant others and family members on how to train people, what does overdose look like, how do you administer naloxone, what do I do, and really calling 911 right away if you can, because with fentanyl it may take multiple naloxone administrations or being admitted to be on continuous infusion. But the other things are obviously clean injection supplies that are in this vending machine too, which I thought was really cool. Drug testing strips for fentanyl and xylazine. So xylazine's all over, mainly in Connecticut. I don't know if you guys are seeing it in Atlanta, but it's predominantly, it's not just contamination of the drug supply, it's actually being sought out. So it's an agent we usually see in veterinary situations, but it does produce a high and sadly cannot be reversed, obviously, with naloxone. So for those who want to test their drugs, you can give fentanyl and xylazine tests strips, but also in ERs and others, you're in your hospital situation, you should be assessing for xylazine as well. So the other thing, and this is the area that I do most of my work now, is how to bring care to individuals who are using drugs, and I think we have to think about that also for HIV, and really thinking about low barrier access to services, mobile health units. This is a mobile pharmacy that we created. We passed legislation in Connecticut to get the first mobile retail pharmacy. And this includes a specialty pharmacy that carries injectable PrEP, ART, Hep C treatment, and everything else, as well as routine medications, diabetes medicines, blood pressures, and community health workers who are trained to go out into the community, blood pressure, finger blood glucose sticks, rapid HIV, Hep C tests, and substance use disorder assessments, and has a pharmacist where you can directly send electronic prescriptions and they can dispense it to them and then help them retain in care. Visiting nurses, home health care model, telehealth, all really can be potentially effective for this population. And long-acting injectable forms. So I just talked about long-acting MOUD, buprenorphine, but long-acting ART, long-acting PrEP, we should be considering this population. Article that just, from Monica Gandhi and colleagues at UCSF, Board 86, showing, not surprising, patients can take these medications in a wonderful study that was presented at Croy Latitude, although it was ART, but populations who are using drugs can take these medications. And I'm going to leave you with the guidelines that were put out 2022, which for the first time included from IAS-USA that included specific recommendations on substance use disorder, and everything that I just said are recommended in those particular recommendations which are here. And I like, just remembering all these extra services that we should be thinking about. And this is for you as well. You can go to the Opioid Response Network and you can actually submit a request for assistance, and they'll actually put you together with an expert in your area that can actually teach you how to do buprenorphine or whatever you want. It's awesome, free. And then the other one is, don't forget that there's a National Substance Use Warm Line that you can call anytime and have assistance about addiction and HIV. And I will end there. Thank you.
Thank you, Dr. Springer. While we're waiting for people to come to microphones, we'll start with some audience questions. If somebody is already on methadone and stable for years, is there any reason to switch them to buprenorphine? Is there any advantage, disadvantage?
Yeah, so remember, it's from the patient's perspective. So if there's an interest for the patient to change, then sure, we can do it. That's number one. But from a safety perspective, the ones that I've had to have conversations with patients about is a very, very prolonged QTC that led to maybe a VFib arrest in the hospital where the methadone was potentially prolonging that, or they had other medications that they cannot stop that were interfering. That would be someone I would have a conversation. We have done where we switch to buprenorphine, including long-acting buprenorphine. But again, just the reminder is medications are very safe, and it's the individual really that it determines if we need to stop or change treatment. So having that conversation with somebody, is key.
And for people that you have on buprenorphine or naltrexone, what is it like if they withdraw, if they stop using? Is there some clinical clues that we should be aware of?
Well, it's for buprenorphine, it's an opioid, partial opioid, so they can go through withdrawal just like going through withdrawal on opioids. It's not as severe as, say, stopping a full opioid, but still they can experience it. And then naltrexone, they don't feel any withdrawal because it's an opioid antagonist, so it's a complete blocker. And I have had patients who prefer, especially those, because I take care of patients who are involved in the criminal justice system, that they're concerned if they are going to be reincarcerated and they're not going to be offered treatment, that they're going to go through withdrawal, which in itself is a horrible thing that I have to say that in 2024, that not all prisons and jails are offering safe, effective, evidence-based treatment to individuals, but it is a real concern for some, so yeah.
And if somebody goes on one of these agents, what is the expectation for how long they will continue? Yeah. Is there treatment for getting off of these? Or?
So the thing is that in itself is a concern. So that second part. So they're effective forms of treatment. They actually reduce death. They reduce the risk of HIV, hepatitis C. For those who are initiating hepatitis C treatment, can assist completion of curative forms of treatment and reduce reinfection with hepatitis C. They could reduce risk of acquiring HIV, and then also other things. So there's tremendous benefits, and there's no data that has shown that the length of treatment has increased the risk. The treatment itself is a risk to them in terms of safety and death. And so there's no need to come off. One thing I always say to patients is, because they start feeling good when they're on treatment, and then when you feel good, especially women who are pregnant or after they have given birth, there's this push to get people off of treatment, and really it's the highest risk of overdose. And so really talking to people about, you feel good right now, let's talk about, there's no rush to get off of treatment, but in that first 6 months is really dangerous, and we know that data without a doubt show that the majority will relapse when you stop treatment, and death is incredibly high right then. And so I talk to patients, if that is something they want to do, what is our plan? So just like that pain question we all were taught when we were medical students, on a scale of 1 to 10 in what level of pain you're in, I do a craving question, and I assess from 1 to 10, like what level of craving are you at right now when you're feeling good, and what level, and then let's do a check. And if your craving number starts going up and you're off treatment, or even if you're on treatment, that's something that we need to talk about. And what are some steps? Because craving, and I won't go into all this, there's really lovely biological data mapping the craving that occurs, and it's not just through actual use. It could be a psychosocial event. It could be walking by a certain area that triggers it and is quickly triggered to use. So really talking about plans and other things of what we're going to do. So, but not to get them off treatment necessarily. But if they want to get off treatment, then we got to have a careful plan.
Okay. And there is obviously in primary care a problem, as it's been well documented and researched about, preventive care and screening. There's so many things that we're supposed to screen for and so many preventive care activities we're supposed to engage in. How do we fit substance use disorder screening in? Which other screening is less important that we need to drop? I mean, this is sort of an inflammatory question, but like, when people come to the doctors and you say, please fill out these 12 screening forms, at some point, it's a...
Well,
right.
one, they don't need to be they could be electronic records where you have skip patterns. I have iPads that my community health workers use and everything. But I would say you have one of the biggest killers in this country right now. It's not just killing people from overdose, and it's not just opioids. It's stimulants, benzodiazepines, it's combination of alcohol, tobacco, some of our biggest killers. It's our job to help identify people. So I would say without a doubt, and also new HIV epidemics, new hepatitis C epidemics, new infectious disease epidemics. So I would say without a doubt, that's an easy one. And we created 2 tools that are less than 3 minutes, non-clinicians can do. So your front of your staff could do, anyone could do, the patients could do. And they could, gives you a diagnosis, audit, alcohol use disorder one. But the key is, what are you going to do about it? So people don't ask me, and I'm like, don't you want to ask, when I see my clinician, don't you want to ask about my substance use? Don't you want to ask about who I'm having sex with, or if I'm having sex? Because, we do biases on who we assess, and it should be universal. But I would say we have a suicide epidemic, we have depression, definitely, are you going to offer treatment? Don't just do the questions. What are you going to do when you get a positive response? And so I think those are absolutely critical. And then, of course, HIV and hepatitis.
And to follow up on that, the Joint Commission famously demanded that we do a pain screening. Why haven't they integrated substance use?
That's a good question.
Can we sue them or hold them hostage?
Well, I think that's the problem with all these things. No one's really talking to each other, but really offering, I have a whole thing about ending the HIV epidemic plan. Awesome. Test everybody, treat everybody, prevent. But there's no implementation plan. There's no discussion about what do you do in a state that doesn't have Medicaid. Like Texas can't offer them injectable PrEP because for those individuals who don't have insurance, and then you can't get testing. So when we make these recommendations, we really have to be proactive in thinking about how are we going to help individuals, and what are they going to do with that information, and namely pain. A lot of people have pain. So how are you going to address that, especially in those who may be at risk or living with an opioid or other substance use disorder? And how do you help clinicians and others help address that and treat that? So I think, I don't know. I don't have an answer to that, but I would say we have to do a better job when we provide those types of things.
Now, fentanyl obviously gets a lot of news, as do some of the newer stimulants, but as you point out, a huge proportion of patients in our country have alcohol use disorder, and this seems to be like a problem that we've just decided to live with. Why has injectable naltrexone not had wider use among primary care physicians?
Yeah, no, it's a good question. I've written about this, and I'm sure others. I think, because it is so prevalent in our society, it's look at the ads, look at everything, and I think that's again going to universal screening. What are you going to do about it? So alcohol use disorder, really talking to patients. So I often do, and really talking about the stages and is this impacting their work, family life, other things. Would you be interested in a form of treatment? I think it's just comfortability. Like it's how comfortable you are. And the beauty of extended release naltrexone is you don't have to stop, except for those who've had withdrawal, serious withdrawal issues. People don't have to stop drinking to initiate it. But you really do see reductions in craving and reductions in use. It may not be abstinence. And in terms of why people aren't offering, I think it's just how comfortable you feel. But it is something that I was psyched about that I could offer as a young fellow when I was a fellow a while ago in my HIV clinic, and you really can see really good results. So I think you got to just give it a go, right?
Okay. All right. Well, thank you, Dr. Springer. Thank you, everybody. I'm sorry there are some questions we couldn't address, but it's time to move on to the next.